Welcome to the Stronger Together podcast brought to you by Sandpoint Strength and Conditioning. I'm your coach, Kenny Marquardt. Today, I am joined again by Dr. Sarah Adair, who owns Revival Wellness Clinic here in Sandpoint. We are going to start doing a series of these. Well, this will be the first in the series. We're going to talk about hormones, men's hormones first, then we're going to talk about women's hormones, and we're going to talk about peptides. We're going to talk about kind of the new frontiers of what we have at our disposal now for tools in treating, all the things. So I'm very excited about this. Her and I talked a couple of months ago, maybe, it might have even been a year. And I was nowhere near as educated as I am and just kind of a bit of a skeptic, kind of gone down the rabbit hole myself on researching and learning and having a lot of people come through the gym who are either under Sarah's care or whatever. And so I'm very, very excited to be having these conversations and start to educate and inform and introduce ideas to you, the listener. So, Sarah, welcome back.
Thank you. Thanks for having me again.
Sure, I'll probably have already said this in the intro that hasn't actually happened yet, but for the listener, sequentially it might be funny, but we did this a bit in the past, and now after talking and having more and more people come to us with questions and whatever, we decided we're going to do a series of these and probably do these for a long time. So look forward to that. But today we're going to talk about men's hormones, men's blood work, what to look for, what to ask about, what to think, what to do about it. We're going to cover a lot of stuff in a little bit of time. So it'll be good. Let's just go broad. Let's talk about hormones, I think, because that's the biggest thing, right? But I've had a lot of guys to talk about, like, what should I be looking for? What are the levels that I should be seeing? When should I be concerned? Because clinically, they are not probably they're being advised alternatively of what would be optimal for them. Let's start there. What should they be looking for hormonally in a blood panel?
Yeah. When we see somebody initially, men, we like to get a pretty broad panel. And we like to look at a lot of different things, not just, a total testosterone, period. I always, especially if somebody is wanting to start therapy, having a good baseline of their liver and kidney function is a great idea. I like to look at their thyroid because sometimes, depending on your level of starting total testosterone and symptoms, sometimes a thyroid dysfunction and low testosterone can look very similar as far as symptoms. So sometimes if you treat the thyroid, you can relieve quite a bit of those symptoms and not necessarily have to start them on testosterone. But always looking at the thyroid, I think, is very important. Sometimes that gets missed. So that's why we like to put it in our panel. And it's not just looking at TSH. TSH is good, but I really want to know what your free T3 is because that's what's working at the cellular level and is mostly responsible for symptoms. So, you could have kind of a borderline TSH and have a very low T3. So that's something that I would treat, especially if you're symptomatic.
Yeah.
So I also like to look at your lipid panel, sometimes insulin and an A1C if there's some suspected metabolic dysfunction, and then cortisol level, because that interplays, that's part of your hormone cascade. And then certain vitamin levels, vitamin D and vitamin B, those also play an important role in hormonal health as well. So we get a pretty good initial extensive panel. And then, of course, monitor those as needed or accordingly to the patient throughout time as they stabilize on testosterone.
Yeah, I love it. And it's looking at the foundation, in my opinion, like from my point of view, not the doctor here, but looking at the foundation, because you can't really build off of a shitty foundation, and you also don't know if that's perhaps what's causing the symptoms. Which I actually wanted to, as you were going through that, I realized I wanted to pause and say, why should somebody come get a blood panel?
Well, I think a majority of people come because they're symptomatic and they want to know what's causing my symptoms. Like all of a sudden I can't do my workouts. All of a sudden I want to take an afternoon nap. All of a sudden I'm sleeping like garbage. There's usually some kind of trigger, but getting annual blood work, regardless of that, I think is a good idea too. So just know your baseline. There's familial factors that come into that, especially with metabolic disorders, your cholesterol levels, that kind of stuff, that even if you're not symptomatic, you should kind of have an idea of what that is for you.
I've talked to many men, especially since our last conversation, now that we've kind of been breaching these subjects, who have felt as though it was depression.
Yes.
Like they had depressive symptoms.
There you go.
That were that were just really a symptom of a low testosterone. And that was it was different. Like I think a lot of guys just kind of felt this feeling of malaise. they felt kind of
Blah.
stuck,
Yeah.
like just not really knowing what to do, which is a very, I don't know, as a male myself, it feels kind of emasculating to say, like, you want to be able to like kick doors down and fix stuff. And I don't know. And that's just like, that's maybe
We like when you do that. We like
Right.
when you do that.
right. But and feeling the kind of like that blob, and not only feeling blob, but feeling bad about feeling blob. It's a weird cycle.
Mm-hmm.
And again, having spoken with a lot of men we've talked to since, that was actually the symptom was actually the depression, but the clinical part was the low testosterone, or lower hormonal or hormones are out of whack.
Yes, and I'd say, I've seen, because we see a lot of military, first responders, police officers, even, PTSD, depressive anxiety type symptoms, that kind of falls in that category, otherwise unexplained, and then get on testosterone and notice a significant change in their mood. Saw it personally with my husband. He was very irritable, little things would set him off, and then, over time as he stabilized on testosterone, just things were less stressful. He was able to handle the stress much better. And depressives, not that he had that, but, across the board, especially with that group of military, first responders, all that, and others, that the anxiety and depression, which can correlate with poor sleep, improves, as you become stable on your testosterone. And a lot of that actually comes from the aromatization of testosterone into estrogen. So part of that is responsible for that too.
Great. Love the segue. Let's talk about what that would look like on a panel. Or, sorry, we can start at the top and work our way down to what that would look like on a panel. But I guess lead it where you want to go from here. But what would be on a panel? What would be the symptoms as a result, et cetera?
So you mean like when you're getting started on testosterone, or prior to that?
Well, I think aside from like those other, so we talked about, vitamins, we talked about like a lipid panel, we talked about thyroid. Okay, that's externally from those.
Okay,
we're
so
talking, let's talk about total free
Okay, yeah.
SHBG all the way down and see how far we can get.
So with males, we're looking at the total testosterone, free testosterone, sex hormone binding globulin, and estradiol, which is E2 or estrogen. So have testosterone throughout your entire system, right? And that gives you your total testosterone. There is a protein called sex hormone binding globulin that does exactly pretty much what it says in its name, is it binds up to sex hormones. So your primary sex hormone for males is testosterone. So that binds kind of like a lock and key. So when that testosterone molecule is bound with sex hormone binding globulin, it becomes inactive. So your cells can't use that particular bound testosterone molecule. The free testosterone is what actually kind of gives you your symptom relief and what works at the cellular level. For example, if somebody comes in with a total testosterone that seems reasonable, let's just say 800, but they have a high amount of sex hormone binding globulin, and there's several reasons for that we can chat about if you'd like. It gives them a low free testosterone. So even though their total looks great, their free is low and they still feel like garbage. So they are still eligible for treatment because they're on that low end. Actually, one of the ways to fix sex hormone binding globulin, so decrease it, is to give them testosterone. So over time, that sex hormone binding globulin will decrease with testosterone replacement, and then we can adjust their demands as far as testosterone dosing as needed over time.
A couple things come to mind there. One is clinically low testosterone would be like under 200 for total, correct? Or sorry, 250. 250, under 250 is kind of, sorry, and I said, yeah, right?
So it depends. So the reference ranges will vary. So if you're looking at a lab and their reference ranges, some define low as less than 200, some define low as less than 300. And then same with the upper limits of normal. It could be 600. It could be as high as 1,000. Sorry. So the range is pretty diverse and pretty significantly different.
Yeah, I think why I brought that up
gap
is like so when somebody gets an annual checkup from their primary care physician who tend to not be very progressive or informed in male hormones, in my opinion, they're going to look at that as the reference range and say, well, your total is over 250, so you're good.
Yep.
Or maybe not, but I've seen that happen a couple of times. Which A is, again, who the hell knows, but B doesn't really have a whole hell of a lot to do with your symptoms, because at the end of the day, it's going to be mostly regarded to your free testosterone. Yeah.
Right. So yeah, if you have a total testosterone on the low end of 200-300, I can only imagine what you probably have very little.
Yeah, that's probably, you're probably not great if you're not feeling great.
Right.
But you may also be 600 and you're closer to the norm range, but you may have a very low free testosterone. And you might, and so that also elicits the idea of, okay, well, you should probably be getting these tests done frequently, regardless of how you feel, where your age is, because you want to watch the trends, see what's happened to you over time.
Yep.
And know where you're normal or where you have been, because it's going to naturally decline over time. And then you'll have a window into that. But also, again, I would be shocked if I had more than one person ever tell me what their free testosterone was, but they know very quickly what their total testosterone was, which, again, may not matter.
Yeah.
So pretty important little designation there. Most people are using the total as the diagnosis, and then also that's kind of wild. And
but a total testosterone is important to get, because it's how we calculate ultimately your free. So both are important to get, but yes, we tend to focus more so on your free testosterone than we do your total. Yeah.
Okay, let's see. Where should we go next? You mentioned some. Yeah, go ahead.
Yeah, we can talk about the sex hormone binding globulin a little bit.
Yep, love it.
And then if you want to talk about estrogen, then after that.
Perfect.
Okay. So sex hormone binding globulin, there are several disease processes that can affect that number. So obesity is one of them. Metabolic disorder, you tend to have a higher amount of sex hormone binding globulin. Certain medications can cause a rise in sex hormone binding globulin, opiates being one of them. The other disease process that can affect that is liver dysfunction and then thyroid disorders. So again, why I like to look at thyroid in the initial panel or at some point during your treatment. Because if the cause of that sex hormone binding globulin is elevated because your thyroid, then that's an easy thing to address. There's also, if none of those factors are in play, then simply aging can increase that too. But again, usually with testosterone treatment, assuming those other things were in play, then that can decrease over time. And then estrogen, so with testosterone, a portion of estrogen, or a portion of that testosterone gets aromatized into estrogen, which is a natural expected process. A lot of the benefits of testosterone replacement therapy actually comes from some of that conversion. So estrogen in males, and of course in females, has a ton of benefit on your cardiovascular system, your brain function, your bone health, your joints.
And libido too, actually, which is kind of surprising to me. Like, it didn't make sense to me at first. So, sorry.
I get a lot of questions frequently, or concern, I would say, about when we follow up with men and they've seen that rise, and it often comes flagged as abnormal or high. And the only time I'm really concerned about estrogen being high or abnormal is if it's causing unwanted symptoms. And in most men it doesn't, in some it does, and of course then we address that either by adjusting dosing or increasing the frequency of dosing. That usually helps, or just simply giving it a little bit more time to your body to adjust. But otherwise, if those things aren't helping, then we address it by increasing that estrogen just a little bit. But I certainly don't want to plummet it, because then you increase your risk for all those beneficial things: cardiovascular disease, decreased bone density, muscle mass, all those things.
Right.
So
yeah, estrogen is not the devil. It's kind of the
not
same thing. It's like a very relative score, and that for you to understand where you start to feel a certain way based on a certain number is more important than the raw number itself.
Yeah, and that kind of goes back to labs in general, as we were kind of chatting about, like, where should my numbers be? And that's a hard question to answer. Like, oh, your level needs to be this. like I want your level to be where you feel good, whether that's 800 or 1500 or whatever it is. Wherever you're feeling well is where I want your level to be. I use your level as a rough guide, but I'm more focused on how you're feeling.
Yeah.
And same with estrogen. You know, some guys' estrogen is 90 and they feel amazing. Some it's 40 and they feel amazing. So, and the difficulty with estrogen is the serum levels are not always super accurate. If you wanted to get, because the receptors live in the tissue, they live in the actual tissue. So if you wanted to get an actual representation of your estrogen level, you'd have to do a tissue biopsy. We're not doing that. There's no need for it. So I try to let my guys know not to get too hung up on these numbers, and especially the estrogen, unless it's causing problems.
Yeah.
Yeah.
Tissue be like...
No, like soft, like no soft tissue, not fatty tissue. Although you do have, if you carry a larger amount of adipose tissue, you tend to have higher amounts of estrogen.
So that's what I was wondering, actually, because if it was a correlative.
Yes.
You mentioned the obesity side of things.
Yeah.
On the side of, again, most physicians being pretty, I don't know what the right word is, slow or uneducated?
Uneducated, yeah. It's just a lack of education, yeah.
Typical testosterone protocols are going... Well, I'm going to ask you, what's a typical testosterone protocol you see from a primary care physician? And I know we probably don't want to get crazy into like dosing, but what do you see and why is that bad? And I'm leading you to something we'll say if I'm...
So what I've seen most commonly from other primary care physicians, not necessarily other clinics similar to mine, but other primary care physicians, is a large bolus dose like every other week. So like 200 milligrams IM every other week.
Right. Intramuscular.
Yeah.
Sorry. Just through the...
Yes. Thank you.
So a giant dose every 2 weeks.
2 weeks.
Why is that bad? Based on what we just said, what we were just talking about.
Yeah, So one, you get this big bolus of testosterone, which is, you're gonna feel really great for maybe 3-4 days. And then as your body absorbs that, you're gonna come right back down. And then that next week you're without anything. So that second week, you're just going to feel like garbage again. The other problem with that potential problem is then you're also spiking your estrogen. And so if you're one of those males that is sensitive to those spikes in estrogen, you're potentially going to feel like crap for those few days too, which could be nipple sensitivity, weight gain, even some sexual dysfunction sometimes if your estrogen's too much for you. And then you get these like peaks and troughs and these crashes essentially. And that's, I mean, especially with hormones, waves like this is not necessarily good for your body.
It's kind of the anti of what we're trying to achieve.
Right. I prefer to do a more steady state so you feel well consistently.
Yep. And so a typical male is on a 24-hour cycle? And so morning testosterone is highest throughout the day, it diminishes?
Correct. Yeah.
Again, every day. Mm-hmm.
That's a normal cycle, yeah.
To do that every 2 weeks and say, here's some testosterone, and then...
and then plummet. Just kidding.
Your body doesn't know what to do. Your body's going to say, oh, shit, we got a bunch of testosterone. We're good. We're going to shut our own one down.
Sure.
We're going to aromatize a lot of estrogen to counteract this big dose of testosterone.
Yeah.
Like you said, you're going to feel great for a period of time, and then back in the trough with you.
Mm-hmm. Yeah.
Which...
That's the potential problem with pellets too, that same kind of, some people do really well on pellets. Oftentimes they get that peak and trough type wave and kind of crash and burn too until they can get more pellets in.
This is a question I'm dying to ask. Why do most women, I feel like a lot of women end up on a pellet. I don't hear a lot of men necessarily. Is there a reason for that?
I don't know, to be honest with you. Pellets, it may be a convenience factor for the clinics. I mean, it is convenient for both ends, right? So it's a procedure, a fairly quick procedure. You put those pellets in, it's a little tiny incision, usually right above kind of your buttocks area. Put those in and you're good, for 3-4 months, depending on how quickly you metabolize those. But it's convenient. But again, the peaks and the troughs is not something I don't think I'd enjoy. I've never tried it, but I'd rather be steady most consistently.
Scientifically, it seems hard to adjust the variable in terms of getting the outcome that you want to, where
Yep. And once those are in, they're in. Adjusting, if you needed to, would be pretty difficult. I mean, the only thing you could do is add. You can't take them out. So if it's causing problems, you kind of have to ride it out.
yeah. Do you work with a lot of men that have problems with that kind of protocol? Sorry, not the pellet, but the like big dose or single dose even. I hear that quite often.
Yeah.
The refrain I've heard a couple times, like, this isn't working for me. Like, I don't think this is the answer. And,
Yeah.
And I'm not a physician, but I'm like, I think you should probably talk to somebody whose expertise this is, because that doesn't sound right to me.
Yeah. Well, and I think traditional teaching of it was that dosing schedule, and now, we know that you can dose it more frequently to get a more steady state, and even inject it subcutaneously. That's safe. You also don't have to give it in a large muscle or anything like that anymore. So I think, again, that goes back a little bit to keeping up with literature and keeping up with updated guidelines and stuff like that. There's really, I mean, as far as I'm aware that I've seen, there's really no updated guidelines regarding these new injection techniques and that kind of stuff from any society like urology or anything like that.
Oh, interesting. So, sorry, you mentioned something too. You can inject subcutaneously versus intramuscularly. The subcutaneous will be a slower absorption, slower uptake, which will cause less of that spike, like you said. Yeah. So if you're getting, on one end of the spectrum would be the every 2 weeks giant dose in the muscle. That's going to be, depending on how somebody metabolizes it, that's going to go hard and fast.
Right. And think about someone like yourself who's very active and works out. You put that medication, it has to go in a large muscle, so your glute, right? And then you go do a pretty strenuous workout, you're going to burn through that faster than somebody who's not. So then your feeling good time frame might be even shorter.
Sure. And again, I think that's why when I was driving, I was like working with a specialist like yourself to understand the variables and the changes that can happen. I'm not sure that primary care physicians don't understand it. I just don't think it's their area of expertise. And so,
and there's a lot of red tape with insurance around all that too. So
got it.
Yeah.
Interesting.
Yeah.
And so again, like lots of variables to change that may or may not even alter a dose overall. So you may have somebody on 200 milligrams every 2 weeks have a very different effect by changing, or by a very different effect if they went every other day or every 3 days on the same exact dose, but a different injection protocol. So anyways, and it's apples to oranges in a lot of cases. So
yes. Yep. Absolutely.
Then, so we were talking estrogen, and then, so on a similar vein, the aromatase inhibitors, which will shut down, or not shut down, but will block estrogen conversion,
Correct.
may again be a strategy used by somebody right out of the gate who is less informed, and will again make you feel like crap, even though that's not, it's masking the overall benefits of what you should be feeling.
Correct. Yeah. So I very rarely do I start somebody off on an estradiol or an aromatase inhibitor right out of the gate. I will start them on just testosterone or whatever, protocol we start them on, and give them the information about, hey, if you start to experience these things, please let me know. We may need to address that, but I don't automatically start them on one. Even sometimes if they become symptomatic, we can still usually monitor those symptoms with changing their protocol just a little bit.
I want to ask you a question, but it's probably going to be such a varied answer. I don't know, but how often does it take? How long does it take for somebody to? How often does somebody do blood work for when they start a protocol? Is my first question. I'll ask you that.
So, of course, we get the initial panel, especially if you haven't had your testosterone or hormones levels checked recently, usually within the year. Once you get started on therapy, then I like to check a dose anytime I'm making a dosage change or starting you on a medication. So 8 weeks after that. So when I'm first seeing a patient, then I see you 8 weeks later. If I'm making an adjustment to your dose, which I usually am at that time, then I'm seeing you 8 weeks after that. And then once you become stable on whatever dose we find is therapeutic for you, then I'm checking labs every 6 months unless there's a symptom that changes or there's a concern that comes up.
And how often or how many blood work panels or how many weeks does it take for someone to get to kind of a period of homeostasis where they feel good? and that's where you live.
Yeah, I would say on average, most men, I can usually get to their therapeutic state within 3 to 4 months.
Right. Sorry, cut you off.
Yeah, no. I was going to say, I know we're talking about women, or men, but women can be a little bit different, usually a little bit longer on that.
Yeah, what I tried to interrupt you with was like, I feel like I've had a couple people, they're like, it's 2 weeks, like not doing anything, not like, well, fortunately, there's more to the story that you'll probably need to tweak here.
Yeah.
So that's just how it goes. I mean, that's just what it is. And
every person experiences their therapy different. So some guys may notice some of the benefits. Usually it's the sexual benefits first. Sometimes within a couple weeks. I would say on average it's usually about 4 to 6 weeks. I generally try to explain that the benefits of testosterone comes in phases. So again, usually the sexual benefits and the starting to feel less fatigue is usually what I hear when I'm in that first follow-up is I'm noticing better improvement of energy. I'm not wanting to take those afternoon naps. I'm getting morning erections now. Libido's good. And then around the 3 to 4 month mark is I've noticed the improvement of brain fog. The fatigue is still not there as it was. And now I'm more motivated to get to the gym or, do better at my job or be more involved with my family or whatever that is for that person. And then usually around the 6 months to a year mark plus, depending on the individual, is where I see that the body composition changes. Muscle mass, decreased body fat. Now, obviously, if you've already had that foundation to start with, proper diet and exercise, you're probably going to see those composition changes before then.
Yeah, I think I'm ready to go into this next part, but the former or the person who is a little bit detrained or has a very hard time getting to the gym or what you name it, what you name the symptom, but it's out there for sure. I think those people have a lot more. It's not necessarily they have a lot more to gain, but it's kind of like a GLP-1 or it's like a kickstart that they're in. It's like, hey, now you want to go to the gym. You look forward to training. Like you feel good. You feel the results. You get a better pump. You don't get your ass kicked by going to the gym and then have to go sleep for 6 hours. Yeah. And then you're just constantly like setting yourself on fire every time you walk in the gym. That's not how it should feel. It should feel good. It should be rewarding to you. And I've seen the most benefits from those people. Yes, of course, the people that are consistent and have been consistent. That's awesome. It's kind of getting them back to like, I don't know, their 20s and they kind of get that rejuvenated feel again. I've seen that with a lot of our people here at the gym. Yep. But more so are the people that like get that fire lit that they have maybe never felt.
Time.
Yeah, and that's I think that's even cooler. And I think there's a little bit of an unlock for them where, again, some people like they've had that, they know what it feels like to feel good in the gym and they know what it feels like to have experienced the positive effects of that. There's the whole class of people who have never felt that way. And now through exogenous hormones are able to experience that. And then this kind of creates a whole new future for them that they never even knew was a thing.
Yeah. It's very true. Yes, for some, it gives them that motivation to make those positive steps, lifestyle changes. Yeah. Not for everyone, and sometimes that takes a little bit more time. And on the flip side of that, it's also not some miracle drug that's gonna, you still have to put in the work and effort to live a healthy lifestyle and let testosterone work for you. If you continue to, live a poor lifestyle, you're not going to probably notice a ton of benefits. You probably still will notice some, but not like you could if you were doing your part too.
Yes, that's. I'm glad you said that because I think there's a conception that you're going to turn into a free show bodybuilder overnight. And for one, there's one side of it that says, okay, well, you got to put in the work. That's a big. The other part of that is you are not going to look like what you probably think that those people who you're thinking of look like by a therapeutic use of testosterone.
Right. There is testosterone replacement therapy. There's super physiologic bodybuilding testosterone. Those are very different.
Which is 3-4x what we're talking about. Multiple compounds. Like that's a whole other.
That's a whole nother. Yeah.
Yeah. And again, but so you're not going to do that. That would be amazing. Those people would save a lot of money and time if they a light dose of testosterone would be able to turn them into that overnight.
All right.
And also, yeah, you got to put in the thing, but you'll want to put in the work. I think, again, that's been the refrain I've heard from most. Is you're like, holy shit, like this, I want to be here today. Like, that's cool.
I feel good. I want to do things. Yeah.
Yeah. And I think that's, we talked about this a little bit last time, but like the other class of drugs, GLP-1s, peptides, and the newer stuff, which I'm excited to talk about next time, is this, it's like, it's not, yeah, I guess those may do it for you. I guess the appetite suppressant part of it may cause you to lose a lot of weight, but it's also, it's probably more beneficial as a kickstart and as a tool to light to a little bit of gasoline on the fire.
Yep.
That will be beneficial long term. So
yes. Yeah.
I think the last part I wanted to get into was like, I think, and I talked about this a little bit last time, is there's almost like a guilt or shame or some sort of like, I don't know, through my generation where testosterone was seen as as a steroid. And that was like, you cross the threshold into the blackness and you're now cheating. And again, I grew up in the 90s. We watched baseball go through. There's a lot of stuff that was a factor in that.
Yeah.
And I think that I guess let's chat about that. Like this is just what it is.
I think that stigma came about when I think that, well, there's a couple things to that. Well, testosterone got put on the controlled substance list having to do some with Olympic athletes. I believe it was in the 70s. That's when that got put on the controlled substance list. And so many of the controlled substances on the list, the categories, tend to have a negative connotation, right? There's the opiates, the benzodiazepines, these kinds of things that can cause addiction, and they're negative and that kind of stuff. Testosterone, there's no addiction properties with them, but because they were getting abused, there had to be some kind of control over it. So that's probably kind of where that negative connotation started. As we age and as we grow up in today's world, exposed to all these endocrine disruptors and all that kind of stuff, I think it's becoming a little bit more normalized or acceptable because it's not something we necessarily have control over all the time. So, choosing to live a healthy life as best you can is your choice, as best as you can control it. If your testosterone level's low and you feel like you could benefit from that, no matter what the cause was, that choice is yours. Live your best life. And it's not, I think we're getting bombarded with all kinds of things. I mean, now we're seeing that, low testosterone levels are associated with PTSD. PTSD, unfortunately, affects many, many, many people, whether that was from combat or, your job or an emotional traumatic event. I mean, there's all kinds of things that disrupt your system. And so, and I think that's part of why it's becoming more normalized and more acceptable. I see more and more men talking to each other about it and the benefits of it. And so hopefully that will continue and it's not as stigmatized as it was.
Yeah, for sure. And the duration of it too. So again, it was like as I was going through this era, it was like, okay, well, if you do it, you're broken after that. Like you can't come off, which is not true, but also not necessarily realistic. Like so you can come off, and
you can.
Maybe why would you?
Yeah, so I mean, you absolutely can come off testosterone if you wanted to. I have very few people that do that because they feel so well on it. But if you wanted to come off of it, there is a safe way to do it, really decreasing your dose, and depending on fertility issues and wishes, there's a different protocol for that, but you absolutely can come off of it and go back to your baseline. There's very rare cases that it shuts down your testicles completely. So, and again, there's safe protocols to come off of it safely. And that goes, coming kind of when I chat with any gentleman that's wanting to get on it, I do discuss fertility as well, especially in my younger gentlemen, because that's a whole nother treatment protocol that needs to be discussed to keep, protect your testicles.
Yeah.
Yeah.
So
no, you don't have to be on it forever, but you can if you want till your dying day.
Yeah. And so you can be on replacement therapy and still retain fertility. We should talk about that for a second because I had somebody ask me that the other day actually.
Yeah. So there's several different medications we can use. HCG is the gold standard for that. There are other medications Unfortunately, HCG right now, because the FDA has their finger on it at the moment, is more on the expensive end. Hopefully that comes back to compounding pharmacies where we can keep costs low. But for right now, it's just the commercial product, which is still available, but that is the gold standard. I do like to use HCG if possible. If not, there are other medications like enclomiphene or Clomid in combination that can help with fertility too. If I always recommend, especially in my younger men, if fertility is you're wanting to maintain your fertility, I do recommend getting a baseline sperm analysis before starting testosterone to know where your baseline is to start with. Because if there's something at your baseline that could be a potential issue, we should know that prior to starting testosterone.
Makes sense.
Yeah.
Is it just a shutting down because you're introducing an exogenous hormone here that your internal stuff shuts down, and then can you explain the mechanisms of that to me? Sorry.
Yeah.
I think I get it subsurface or surface level, but I like to go a little deeper.
So if you give your body an exogenous, a medication hormone, your body then is going to make less of it because it receives the signal at the receptor like, oh, I've got this. So I don't need to tell the pituitary to send another signal to my testicles to produce more FSH and LH. So
Got it.
FSH and LH are the two hormones responsible for your sperm and one for your testosterone. If testosterone's coming into your system, getting into your receptors, then your testicles aren't pulsing as frequently, saying, hey, we're out of testosterone. Keep it pumping. It's already in the system, so they don't have to work as hard.
And the creation of sperm is a byproduct of the creation of the testosterone. So the pituitary gland sends the signal, testes create testosterone
and sperm.
Got it. And so without that, when the loop gets interrupted, then
both
sperm
of those go down.
Yeah, understood. Okay, got it. And then so the HCG does what as a mechanism to retain that?
It tells your testicles to produce more. Essentially, tells your pituitary to send those FSH and LH signals. So your testicles are still making the sperm and the testosterone. So that's why sometimes, depending on the person, can increase testosterone production with HCG monotherapy. So you could take just HCG and increase your testosterone.
Interesting.
Mm-hmm.
What are the benefits to that or why would somebody go one way or another?
It depends. That can work assuming that there's no problem with that communication between your pituitary and your testicles. So if there is a HPA axis dysfunction, HCG is not going to help that. You still have to be able to receive those signals for HCG to be effective. Tend to see that work a little bit better with someone who is at the higher end of the ranges, if you will. Because it's not going to likely take you from a 200 to a 1200.
Sure.
So that the other downfall with that currently is how expensive it is.
Is that a byproduct of age? Like I know testosterone is going to diminish with age. Does then the sperm production decrease with age too? Is that a signaling thing, or is that just do we know?
Yeah, as we age, both those hormones, so luteinizing hormone and follicular stimulating hormone decline over time. So yes, that's why both the sperm production and testosterone levels decline over time.
So I kind of paused during the question because I was thinking about do we know why? Because as a broad survey, I think it's understood that testosterone levels are the lowest they've been ever in men. Do we know? I mean, you alluded to a couple factors, but do we know specifics of why, or what the heck's going on here?
I don't know that we know specifics, but I think the general consensus is all the endocrine disruptors, all the plastics we're exposed to. We're now seeing what the COVID vaccine has done for fertility on both sides. Lifestyle is a big one. We're becoming more sedentary, unfortunately, in our life. Our diet, what we're exposed to, lack of nutrients, other chemicals in our food sources, so in the air we breathe. It's all the disruptors is the common consensus as to why it's happening. And they're saying it could be even, they suspect that exposure even happens in utero. So we're behind the ball.
Yeah.
When the
Huh. Interesting. Yeah, and there it goes, I think, ties back into the stigma around this where people feel a certain way. And that, yeah, this is just kind of the state that we're in.
Yeah. And I mean, if we continue at this, at this pace, this steady decline over time, it's really disturbing. It's hard to say what will happen, over decades.
Sure. Yeah. Well, I don't think it's going to be great. I mean,
No, I'm not sure. Yeah, not a good thing.
yeah. Okay, we're about 45 minutes. Anything we did not cover that you wanted to cover?
I don't think so. Peptides, I think, will be a good thing,
Yeah.
as we talk about body composition stuff, as your study on testosterone, once you're feeling good, and then I hear a lot of the time, like, what else can I do to gain muscle and, feel better? And the anti-aging stuff is becoming pretty popular. So I think we want to focus all that with peptides.
Yep. No, I'm very excited for that. And by the time we do it, there's probably going to be some new stuff on there too, which will be great.
Well, I know Kennedy is pushing real hard and he's making progress. So they're talking about pulling 12 or 15 of the peptides back on the compounding list.
Yeah. I thought it was 13. That was the number I popped into my head. So I don't know, but it was enough that it was like, wow, cool. Like we're headed in a positive direction that way, in my opinion.
Especially the most common ones.
What? Sorry. So I did, this is where I'm reintroducing something here at the end, but negative side effects as far as like blood panel. So like hematocrit, like producing more red blood cells on a protocol. Like, what are some things to watch for there? And again, that's where you come in, but sorry.
So as far as blood work, potential negative things that can happen, really, I mean, there can be the increase in estrogen, which again, most of the time is not a bad thing. And then you mentioned, the hematocrit, hemoglobin. Getting back into reference ranges, I would say because a lot of our primary care physicians use LabCorp or Quest. Their upper limit of normal for a hematocrit is usually about 52%. My reference range on my labs, because they specialize in hormones, is a little higher. So 56 is their upper limit of normal, so 56%. I don't really start to get worried until the 60%. Hematocrit is very sensitive to hydration status. So if you're fasting for your labs, if you're dehydrated chronically, you tend to have a more elevated hematocrit anyway. So there's a discussion around that if your hematocrit comes back a little bit elevated. Are you staying hydrated? You were fasting for your labs, so let's have you not fast and be hydrated and see what your hematocrit is. And it usually comes back normal. If it doesn't, then I'm adjusting your protocol. So I may need to increase your frequency of your injections or decrease your dose just a little bit. Allow your body to adjust to testosterone, because I typically see it at the beginning more than persistent. There's a primary, so the concern with the hematocrit being elevated is erythrocytosis, which is just an abnormal production of red blood cells. There's a primary erythrocytosis, which comes from blood disorders, certain types of cancers, this kind of stuff. And that is a concern if it's primary. If it's a secondary erythrocytosis, which can come from testosterone replacement, it can come from sleep apnea, that kind of thing. You're not at an increased risk of heart attack and stroke with a secondary erythrocytosis like you are a primary. And so I think there's a lot of confusion out there. I hear all the time, like, hey, I took my labs to my doctor. They want me to get in and do therapeutic phlebotomy right away. And I'm like, I'm not concerned with it. Are you symptomatic? Of course, that's always first thing. Are you having chest pain, shortness of breath, headaches, blah, 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 palpitations? No? Okay. So let's change your protocol a little bit. Stay hydrated. Let's recheck your labs. The other problem with frequent therapeutic phlebotomy, one, it will decrease your hematocrit for like a week. And then you're right back to your baseline. If you are phlebotomizing frequently, you can dump your iron stores and then you're going to feel like garbage. So now I'm having to treat your iron deficiency from phlebotomy you probably didn't need. So I know some clinics require phlebotomy, like quarterly or whatever it is. I don't require that. Now, if you want to, because some guys do and they just like to and they feel good when they do that, then by all means. But it's not because I'm worried about your hematocrit.
Yeah, got it. Blood pressure, same thing. Like I've heard quite a few people come back in, like my blood pressure went up the first, like they just gotten started. Blood pressure goes up.
Yep, it can. Yes. And that's something that needs to be monitored. Again, as your body adjusts, it likely comes back down to your baseline. If not, we make adjustments in your protocol.
And weight gain. I hear that a lot too.
Weight gain, that's tricky. So if it's associated with the estrogen, the negative effects of estrogen, one that can take time for your body, again, to adjust. We've got to allow your body to adjust. It usually resolves. If it doesn't, then we need to address the estrogen. Sometimes it's associated with sodium shifts. And if that's the case, it's usually temporary. It puts you on a diuretic and it usually resolves. The other thing that that happens, and it happens more frequently than not, is I'm gaining weight. Okay, let me get you on the in-body scale. It's muscle.
Yeah. Cool.
Yeah. So I encourage all my patients, it's free to use the in-body at any time. That's often what happens, is they're gaining muscle and losing body fat.
Yeah, which is a great side effect.
That is a great. That's what we want. Yeah.
Okay, cool. We were about to finish about 10 minutes ago, and then I tossed that one back in there. But
Yeah.
I think that was well worth talking about. And I think in the context of it all is like working with somebody like you whose specialty is this makes all of the labs that are important easier to discern and understand and figure out what actually is to be done and the corrections that should be made rather than, I don't know, I'm usually pretty good with analogies, but I'm not coming up with one for like a primary care physician to like do the thing and be like, we got to do this or that. And it's kind of, it's just not the sharpest tool for the job.
Sure. Yeah. I mean, and that's true across any medicine. I mean, if you need a specialist, you should absolutely see one. Not every person is going to have all the knowledge for all medical, like a primary
Sure. Oh, yeah.
can't know every specialty.
Good point.
So, I don't necessarily blame it on the primaries. It's just, you can't know everything. We can't know everything.
Yeah, I think my concern becomes when they don't refer out, because that's a whole other conversation. But it's like, well, I talked to this patient who's their patient. They come into my office and they start telling me they're experiencing these things. I'm like, well, why in the hell are you doing that? Like, that doesn't make any sense according to what I understand. Go talk to Sarah. And then, so anyways, that's where I get a little bit
Sure.
crossed up about it. So
Sure. That's fair.
yeah, I guess the point is just go see you, get your labs,
Go see
whatever you do about them, whatever you need to do about them. Like, I don't know, like you can make that decision, but to see your labs, see how you're feeling, make a correlate of where you're at right now, and then make educated decisions, and then continue to make educated decisions based on what you go from there.
Absolutely.
It's probably the right answer.
Yeah. Yep.
And then once you feel like a god again, you come talk to me, and then which again, like I've seen that so many times now. It's just been like, oh my gosh, like this is magic. Like this is so good for people. They feel like I actually said this in regards to females because I'd heard it so often with where they got on HRT and they said, I feel like myself again. I'm hearing it so much more with men now who come in to my office and say, I feel like myself again. Like this is amazing. Like let's go. Let's figure out some real goals rather than just like trudging my way into the gym is the only goal I can come up with.
Yeah.
So cool. Finding you is as easy as your website, revivalwellness.com.
Yep. Revivalwellnessclinic.com.
Got it. Perfect. And
All the info's there for both Hayden location and Sandpoint.
cool. And we're going to do this again here soon. We're going to talk about females. We're going to then move into peptides. We're going to then maybe start back at the top. I don't know. There's a lot to cover. So
there will be something else to talk about, I'm sure.
Again, super excited about the whole prospect of it and just having somebody like you as a resource here. So thanks for what you bring.
Absolutely. I love it.
For those of you who are listening and have questions, reach out to either of us. I'm Kenny at sandpointstrength.com. Sarah, do you want to put your email out there and people can harass you?
Yep. So any general inquiries can go to info@revivalwellnessclinic.com.
Cool. Awesome. Well, thanks again, Sarah. We'll talk to you soon.
Yep. Good to see you. Bye.
All right. Thank you for listening. Once again, you can find Sarah at revivalwellnessclinic.com here in Sandpoint. And you can find me at Sandpoint Strength and Conditioning. And again, I think that like as I close out that episode, and the two of us, what Sarah can provide for you and what I can provide for you in terms of just living your best life is amazing. So go talk to her, come talk to me, and be a freaking better version of yourself. All right. And you can find me, Kenny, at standpointstrength.com or just at standpointstrength.com by itself. And I'll talk to you soon. See ya.